Hello, good afternoon. Thanks for joining or staying if you're already with us today. So my name is Triana Lobaton. I'm leading the IBD unit here at University Hospital in Ghent. And it's my great pleasure to introduce you to the IBD session in endoscopy. So in this third GIEQs edition. And so we have the pleasure to have this year a great faculty. And we selected several topics that we think that are covering most of the problems that we face in the daily clinical practice when doing endoscopy in IBD patients. And we hope that these are also interesting for you. And to do so, we have actually 4 lectures. So some of our speakers will be online, but then also present for discussion. Some of the lectures will be here in the studio. We also have one live case of one of our IBD patients. And finally, we also have, as novelty this year, one of the videos that we did with our IBD patients. So we are very enthusiastic to share this with you because this is completely new in GIEQs. And we also hope that you like it.
So based on this, a task force, we created this IBD task force with the European Society of Gastrointestinal Endoscopy, and the aim was to identify performance measures for colonoscopy in IBD patients that were widely applicable to endoscopy service through Europe and other interested countries. Therefore, based on this, these are our methodology. We met and discussed between experts, endoscopists, gastroenterology, experts in IBD, possible performance measures in endoscopy IBD. We developed the GIEQs for literature search and to support the proposed performance measures between June and September 2021. And at least 2 voting rounds in line the 5 process were done. And after developed the performance measures and to consolidate the acceptance, we did other 2 rounds of the 5 consensus. What is the future? Do we need all this die, no die, virtual? The future is the artificial intelligence. You can see with artificial intelligence, you can detect the lesion even in inflamed area. So look at it's just pointed out the lesion. And of course, you can use magnification and you can use also dichromendoscopy. But the future at the horizon with the new scopes, they can see histology in real time, like the endocytoscope, the endobrain. The new artificial intelligence, so you can see here, you can see the nuclei, and they tell you what is the biopsy, if it's invasive cancer, and if it's invasive cancer, and also if the patient needs guided resection, and if it's not a good sample. And also, this is another study, was my presentation at DDW, where the CAD for polyp was, was also used for IBD. So what is the message to take home? DCE or VCE at the moment with target biopsies are considered standard care. I always recommend to start with DCE and then gradually move to virtual chromendoscopy, take still random biopsies in high-risk patients, standardized terminology. It's really crucial to speak the same language, especially when you need to refer the patients for resection. Characterize the lesion with, optical diagnosis, switch. Is it just real time? Personalize real time. How to personalize real time the endotherapy? ESD for IBD is a technical difficulty, should be done by the experienced endoscopy. In the future, the horizon is the artificial intelligence for detection and characterization. And also, the future is guiding therapeutic intervention. A good day. Thank you very much.
That's probably one of the most challenging things when you start doing that. Also, coming back to the fact what you're going to use, I think we have published now a nice consensus on training in using these techniques, because it's obviously high time that everybody who is engaged in following up these patients actually does these screenings accurately and how it should be done. And it's really not so difficult. So we took into consideration the learning curve we all went through. Just as Marietta said, I mean, she's not using dichromendoscopy anymore like many of us, but obviously we all went through the learning curve of using the dichromendoscopy before we engaged into using virtual chromendoscopy. And that is what we now have translated into the training curriculum for optical diagnosis, which you can find was published 2 years ago, I think now, or a little bit around that. What we say there is that you can start off at the beginning with backup biopsies. So you take the random biopsies and you do classical chromendoscopy like this, right? And you can see nicely, you get acquainted then with these normal pit patterns, the normal features. You see a bit of inflammation here again, right? And if you start to see lesions like this, you also get acquainted with using the technique of searching the faults, right? So you pull back slowly, and one of the advantages is that you have to go back and forth, you have to rinse, so you learn this. So you do 20 cases like this with random biopsies as a backup. Then you go on to targeted biopsies, chromo alone, and then you take a step back with your virtual. You start doing virtual chromendoscopy, again with backup biopsies in 20 cases, and then you're done. Then you do 20 more with targeted biopsies, look at the outcome, and then you should be ready. So this is something you can do yourself. You can keep track of that. And in the future, I think we're going to come with certification around that. So it's actually a very nice structured way, which is based on experience of people who have gone through these learning curves.
So in a normal bowel wall, you have these nice layers that you can see. And due to edema, you will lose this stratification. And when you use color Doppler, you will also see hyperemia. And then you have some extramural signs of active disease. It's hyperechoic mesenteric fat, and you can sometimes see enlarged lymph nodes. Also, you can use ultrasound for complications and mainly abscesses or strictures. So here you can see two images. The upper image is a grayscale image. You can see the markedly thickened bowel wall with loss of layering. There is edema. It's hypoechoic. And also you can see the hypoechogenic fat around the affected bowel loop. And then the image below, you can see that there is hyperemia in the bowel wall and even extending into the fat. So this is clearly active disease. What are the advantages of small bowel ultrasound? Well, it's availability, so it's bedside available, it's easy to use. It's also inexpensive. You don't need bowel preparation. There is no IV contrast unless, of course, you do contrast ultrasound. And a major advantage is that there is no radiation exposure. So then our final technique is MR enterography. This is our power tool. So this is for the more experienced handyman for serious repair jobs. It's also the most expensive technique. So what is our imaging protocol here? The patient preparation is the same as for CTE, but we do give Buscopan during the examination because the acquisition time for an MRE is longer than for a CT. It's about 20 to 25 minutes, whereas a CT is only just a few seconds. So we have to calm the small bowel and give an antiperistaltic agent. These are our sequences that we use in our hospital. Optional, we look at the bowel motility as well. So what are the features of active disease? Again, the bowel wall thickening, but MR has a better soft tissue contrast resolution than CT. So you really can see the edema in the wall, which will be T2 hyperintense. You will again have the increased bowel wall enhancement, and also we have diffusion weighted images, so you will see diffusion restriction in active disease. And actually this means that there is high cellularity in the tissue. So in inflamed tissue there are a lot of, you have high cellularity, so this will be restricted on diffusion. extramural, you will see edema in the mesentery. You have again the engorged vessels, and you can see enlarged lymph nodes, and of course you can detect complications. For MRE, we have validated activity scores where you can grade the bowel severity, the severity of the inflammation. And one of the most well-known activity scores is the MARIA score, the Magnetic Resonance Index of Activity. You can see how it is calculated here, but as you can see, it is quite complicated.